Oh yeah.
I'm just standing here thinking, okay, what am I going to say next? Because I had nothing to say. Your job was up for grabs, so we were trying to figure it out.
Oh, okay, that would have been good.
Okay, are we on the air?
Yes.
Oh, we are. Well, Dr. David Gardner just joined us, thankfully. Okay, welcome to the HRM Chapter meeting. My name is Donna Mettot, and our techie is, I always say techie, sounds good, is Todd McMillan. He's our resource person at the SSNS and does our live broadcast. So tonight we are here, we have Dr. David Gardner, who is a terrific pharmacist who is an expert in antipsychotic medication. So he's going to be able to answer all your questions, and I'm very curious about the title, The Truth About Medications. And of course, Dr. Gardner will also be telling us about the new Bloom program, which has been in effect for 2-3 years?
A little over a year.
A little over a year?
Yeah.
Okay. All right, so I'm going to let Dr. Gardner take it away. Dr. Gardner, by the way, is with Dalhousie University, and he's a professor there, and he is also with the early psychosis program, and he's probably with a whole lot of other things. So thank you for coming, David.
Sorry, I'm late.
Yeah, no problem. It's a small heart attack.
So when you have a heart attack,
What can I take?
it means that a little part of your heart has died.
Oh.
So you're telling me I caused that too? I'll tell you a different word though. When your heart causes you pain, but then when it goes away and everything's healthy again, that's just angina. So maybe I caused a little angina today, but not so much a heart attack. I hope anyway.
I do have your chart paper.
I know, but I don't have a...
I have, well, I was thinking I could tape it to the, I don't know if they'd like me to tape it to
Probably not.
the, or the board,
Yeah.
or the wall.
And I just happen to have a
I've got markers, I have markers too.
If we need to, but
Need to?
the
Okay.
alternative is hand signals. So
Okay.
I can resort easily to hand signals.
I know you're very flexible.
But I'm sure you're all wondering why I'm late. Right? And I see,
It's good
I
news,
see,
is it?
oh no, it's just nothing. Because I see, quite a few people come with their partners. And it's nice to have supportive partners in life, right? And so the
Little
reason,
story here.
the reason I'm late is my wife didn't remind me early enough.
Oh, of course. You're just lucky she reminded you, David.
I would not be here if she didn't. So I was busy about things in the area. I don't know what triggered her, of course. She was looking at her phone, and we share a calendar on our phone. She goes, "Oh my goodness, you gotta go." And I go, "Oh my goodness, I forgot." So here I am a few minutes later. As I think everybody knows what my style is, except for the people that I have not met, but I've seen a number of you, maybe the majority.
We have you live on camera, by the
Right.
way.
So
I don't think I told you that.
well, I think the last time I saw this little doohickey thing,
Oh, okay.
so I remember that means somebody might be out there. And do they communicate by typing or by any other way?
Typing.
Typing, okay. So please type in your questions. So you wanted to know what the title
Ooh.
is. So the title is The Truth About Medications in Mental Illness. And I would hope you would see right through that, because what I do is talk about the truth about medications and mental illness. It's not like I'm going to come in and do something different this time, right?
Or that you haven't before.
But it's like you're kind of saying, well, Dave's going to talk about the truth this time. So I hope it's or it's not a talking kind of interactive session that we've had in the past. But I'll tell you a little bit about the Bloom program. So over the years, we've seen that a lot of people through sessions just like this, and specifically this session, don't know what they need to know. And we all recognize that when medications for mental illness are started, the road is never straight. And the road is often full of painful dead ends. And we don't have enough people supporting you folks and supporting your loved ones to go down that road in an informed and insightful and a participatory kind of way. So we look at who is around. So everybody remember that 2012, the government, the NDP government commissioned a mental health and addiction strategy. Everybody remember that there was a strategy commission, and it was completed, and the strategy came out with, I think it was 63 recommendations, and the government of the time responded very quickly with their document. And so there was basically a fund set up to try and respond to this. So certain projects were identified to be funded that would help improve the mental health and addictions system as we know it. So we had been doing a project called More Than Meds around that time, and More Than Meds was the training of pharmacists with people with lived experience of mental illness to go back to their communities as a pair. So pharmacists had been trained by physicians and had been trained by other pharmacists. So training each other, and we're all kind of like, whoa, you need to know this kind of stuff. And it's completely different when you train together with people who live it and who live in the same community as you and have a very different perspective than you do. So our training was not about you need to know antidepressants better, and you need to know antipsychotics better, and you need to know benzodiazepines and sleeping pills better. Because that's not going to make a change. What's going to make a change is really connecting with your community. So our More Than Meds program, the ancestor, if you will, to the Bloom program, represented getting pharmacists out into the community to engage and support people living with mental illness in different formats. So what we did was we said, go back to your communities and find 5 more pharmacists. And as a pair, the pharmacist we've trained and the person with lived experience representing the community, go back and train 5 pharmacists. And so we had 6 pairs go back to 6 communities and train over 30 pharmacists. And then we asked all pharmacists who were trained in the More Than Meds program, either directly by us or secondarily by the trainers, we said, now go out and do something for your community. And we're not going to tell you what to do. We just want you in this program to just go out and support. And so some of the pharmacists, we didn't have money. You know, we had money to do some of it, but we didn't have money to pay people to go do it. So some of the pharmacists went off and did that, and they did it alone, or they did it with their community partner. And lo and behold, it worked. It really made a difference. So just from some anecdotes, Shetty Camp, the pharmacist that participated in it from Shetty Camp, he went out and he did an evening in Shetty Camp on medications for mental illness. And a bunch of people came, you know, so they don't have what we have in Halifax, where people are really gifted and experienced with building support groups. And we had people who went to the session fill out a written feedback, and we got all the feedback, and that was part of our analysis. And one person said, I never knew that there were other people in my community experiencing depression like I do. And for her, just tell by the handwriting, don't know the name or anything, for her, it was an awareness that she never would have had if that pharmacist hadn't just said, I can organize that. I don't need somebody else to organize that. I can do it. And like what we always do, it seems like the feedback we got reminded us that these kind of sessions where a pharmacist walks in the room of people to help them get questions around their medications answered is so much more powerful than just me giving you answers about medications, because the room sets up a natural support group and new connections and a feeling of worth and importance that you wouldn't otherwise get if you sent me an email and just said, please answer this question. And I answered it, and I don't know who you are, and you don't know who I am. You're just getting some sort of email. Nobody else is around to say, oh, I've had that happen as well. So that was one anecdote. Another one that was maybe more important was the one from the Valley, where there was a similar evening session run by a different pharmacist. And at the end of the session, the MLA, this is why it might be more important, the MLA from that area happened to just be going by where the event was happening and popped in to see what it was about. And the people gave the MLA the information that it was a really, really useful thing that the pharmacy group were doing here in this part of the valley. So we got, I guess, emboldened by those experiences that the idea of having pharmacists engage more coherently with their mental health and addictions community is really valuable. And so we started to think about how to activate pharmacists. So I've been an educator, a professor to probably 18 graduating classes of pharmacy students at Dalhousie. And I have been, professor to the psychiatry residents and teach psychiatrists and family doctors and pharmacists. And working with Andrea, who is the person that reminded me to come on projects like the mental health projects, we thought, you know what, let's go for seeing if we can get funding through the new opportunities here in the province. And so we changed the program from More Than Meds to be a clinician-based program through pharmacies. So when I say clinician-based, I know, because I've taught pharmacists for 18, 20 years, what they know and what they're trained as. And I know they are clinicians. But I also know their jobs sometimes prevent them from being clinicians. So they're in a retail environment and they're trying to be clinicians. And sometimes the pressures of the retail environment prevent them from doing all the things they're capable of doing. And I think it's important for us to talk about the fact that when you think of a pharmacy, we have to think of how does it keep its doors open? What does it do to keep the business running so that the pharmacists are there at 8 in the morning and at 9 at night so that people can access them? What do they do? And the answer is they sell a lot of stuff. They sell and sell and sell. And it's actually stuff that they sell. But they're clinicians, and you shouldn't be selling all the time. You should be sometimes stopping selling, if you know what I'm getting at. So sometimes our role is to say, you're on lots of medications. You're actually on too many medications. We should stop some of these medications. And this is a new buzzword, de-prescribing. So if you put de-prescribing into Google, and you do a history on that word, you'll see that it's gone from nothing. But in the last few years, it's through the roof as a search term. And I'm on a national board that's all about de-prescribing. And it's especially relevant to the elderly, who are probably, in many cases, taking medications that are causing harm, not good. So what we're thinking about with getting the pharmacists involved is how do we incentivize, how do we promote change in behavior of the pharmacist who has been there trying to sell stuff for the longest time. What we want them to do is help people get well. We want them to help stop side effects, right? There's a way to turn that noise off.
Is it?
Yeah.
I didn't know that.
Yeah, there is. I don't know how right now, but I saw everybody looking at you. I wasn't thinking about it. Oh, what are you guys looking at? Oh, I know. You were being judged. But you know what? I'm glad you were writing it down because you were writing down something I suggested you look into, right?
Yes.
I don't even know, but I'm just helping her out. We've dug her a hole and we're helping her back out. So the program is Donna comes in, and I know Donna, and I say, Donna, I see that you're switching your medications again. And so what would bring Donna into the Bloom program? She's not doing well. Her symptoms are not managed as well as they could be. And sometimes as well as they could be, you could be getting rid of them or minimizing them. Or she's experiencing side effects that are impairing your physical abilities or your mental abilities or your judgment or something along those lines. So symptoms, functioning, side effects, adherence. I think we've all had experiences where it's like, I don't need that stuff anymore. And then everything falls apart. So people who have a history of non-adherence are very much welcome for the extra support that comes along with the program. Or polypharmacy. We call it inappropriate polypharmacy. Do you know what that means? Too many meds. Meds that you don't need. Now, as I mentioned before, the old incentive is just keep it going because it keeps the cash register ringing, it keeps the pharmacist paid, it keeps the pharmacy doors open. But polypharmacy is that deprescribing thing where we're trying to simplify things so there's less medications per person and therefore less revenue per pharmacy because of the deprescribing. So you can see how that might stick in the craw a little bit if you're the business manager or the owner of the pharmacy going, what are you doing? What's this new program about? It's actually cutting down my revenue instead of improving it. And then the last one is stopping medications. So I think we should try and stop a lot of medications. We should stop antidepressants. We should stop antipsychotics. We should stop sleeping pills. We should stop anti-anxiety medications. Can you imagine? You're 18 years old and you're put on an antidepressant. That's it. For life, you're stuck on it. Or an antipsychotic or a sleeping pill. We have to stop them, right? Now, for some people, they are on it for a very long time because their illness warrants it. But for a lot of people, that's not the right idea. But they end up on it for a long time. So what's the classic? Sleeping pills. The classic is the sleeping pill, and especially in older people. So, sleeping pills in Canada, do you know the Health Canada approves it and says the longest that Health Canada has approved for the use or the prescription of a sleeping pill, the longest duration, do you know what it is?
No idea.
Health Canada approved sleeping medication, take a guess. The longest one.
2 weeks?
It's 2 weeks. You're very good.
I don't think so.
But your answer is completely contrary to what is seen in practice.
Yeah.
So years for many people.
Yeah.
So every single new sleeping pill and all the old sleeping pills have the exact same recommendations in their prescribing information. This pill is for acute cases of insomnia. It is not to be used for longer than 2 weeks. That's what it says. How long have they been researched? Every study in a person, it's about 2 weeks. So it's not years of exposure and we know what happens to people. So, have you ever known somebody to try and stop a sleeping pill after years? Or an antidepressant. There's many antidepressants that are quite challenging to stop. They can cause a physical withdrawal. And if somebody is going to stop an antipsychotic, so in the early psychosis program, these are individuals where the diagnosis is not as set in stone as somebody who's 35 or 40 and is on an antipsychotic or a chronic psychotic illness. So some people do stop it. I just got a publication with a serious side effect called oculogyrate crisis associated with antipsychotics, where your eyes fix up. So you're going along your day, and then all of a sudden you feel the muscles in your eye pulling your eye straight up, and you have a fixed stare up. It hurts. If we all did that and held it for a few minutes, you find it's quite painful, very uncomfortable, and dangerous. And this was recurrent. So we had 8 out of our 400 patients, which is a pretty high proportion of them, have this side effect over a few years. So one of the patients was a mother driving her car with her child in the backseat when it onset. Another was a young boy, 15 years old, who was already ostracized because of his differences, who had it, and he was about 1.5 miles away from home, and he had to walk home like this, because if he walked home like this, he wouldn't see where he was walking, so he had to put his head down so he could see where he was walking. And in all cases, it was recurrent. For some people, daily. So we had to figure out how to switch the medications around and so on. So it was kind of funny, because 2 out of our 8 patients, we had to stop the medication. So those 2 did well. You know, we would not have stopped the medication had it not been for that side effect. But they didn't relapse. They did other things that very much helped. So even sometimes we think about antipsychotics for psychosis, these very difficult mood disorders that you're on it and you're on it for life. That's usually true, and history proves itself. You go off it and you relapse, and you go off it and you relapse, and you go off it and you relapse. But that there are a small proportion of individuals that do go off it gradually and do well. So the Bloom program is to help people stop medications. So there are 5 entry criteria, and I said them. Are you guys listening? 1 was symptoms, 1 was side effects, 1 was adherence, I guess 1, 2, 3, adherence, polytherapy or polypharmacy, and withdrawal from treatment. Those are the 5 entry criteria, as long as you have a diagnosed mental illness, to go along with those prescribed psychotropic medications. A pharmacist will work closer with you. You actually enter into the program, sign a form, go through an initial assessment with the pharmacist to identify what are your medication-related issues and what are your priorities, and then the pharmacist contacts your team, and often that's a family doctor. Some places in Nova Scotia, it's just one person is your team, it's your family doctor. And in other places, in the bigger centers, it's actually a team, and you contact the main person. And they say, well, I've met with Jimmy Smits today, and we brought him into the Bloom program, and we identified a few problems that he wants to work through. I'm just letting you know that he's now in the program, and so we want to make sure we're all doing this together. He says X, Y, and Z about what he's already tried or what he's interested in doing, so let's work together. And the pharmacist and the physician and the family and the patient are hopefully a cohesive, collegial group working towards resolving whatever those problems are that brought them into the program.
I was just wondering, how congenial are they? What has been the response from community doctors and the team to having the pharmacist included as part of the team?
So it's been mixed, but it's really good. I think it's getting much better. So in rolling out the program, implementing a program, and I don't know what your initial thoughts are, but it's really different. It's not the kind of thing that people expect a pharmacist to be leading, if you will. So when we were developing the program, we put together a steering committee. So the steering committee has community members, people with lived experience of mental illness, has a psychiatrist and a family doctor, some community pharmacists, and some egghead university types. And so we thought we, had a pretty robust plan, and government is very much involved in it too. But it's so hard to get the word out. Like I asked you guys, and a few of you knew about it. But there's only so much money to do a demonstration project, so we can only have it in so many pharmacies. So it's not like a program that's in every pharmacy across the province and it's easier for people to learn about. So we have a demonstration project and communicating it and getting it out there. So inevitably, there are people who are hearing about it in a way different than how you're hearing about it today. And who say, well, pharmacists can't prescribe, but they're not prescribing. And pharmacists can't diagnose, well, they're not diagnosing. And pharmacists can't take away my patients, well, they're not taking away your patients. They're collaborating and supporting and identifying resolvable problems and helping people through it. Well, why are pharmacies getting paid? So remember I said we have to incentivize people in a different way? So the pharmacies are getting paid a monthly amount to support individuals in the program. So if you come into the pharmacy 3 times a week the first week, once a week the second week, no times the third week, and once a week the fourth week, you get 1 flat fee. If you come in the next month just once, you get 1 flat fee. So what we have is a very different fee structure. So you guys know about fee for service, right? So the pharmacist is not incentivized to bring you in and bring you in. The pharmacist is incentivized to give you the care that you require. And so we have a component in the program to ensure good quality control and good quality assurance. So we want to make sure that what the pharmacists are providing is necessary care, is evidence-based care, is holistic, is collaborative. And so we're going out and seeing how they're running the program. And then the evaluation has just started up. So we had this angel fall from the skies who is an evaluation expert who will be hired over the next year to conduct an evaluation of the program and see how it actually helps. So I just had one anecdote cross my, let's see if I remember it correctly, cross my email today, earlier today. And it was somebody who went into the pharmacy for a flu shot. And in waiting for, after you get your flu shot, you have to stay for 15 minutes in the pharmacy just to make sure everything goes okay. Saw the sign saying Bloom program, said, oh, what's that about? Started to talk about the patient's antidepressant and was saying, well, I'm not doing well on my antidepressant. And so saw, hey, this is somebody I've never even thought of as a resource in my community. But they're so accessible and they're here every day and they're already trained. They're trained in the medications and they're trained in the illnesses. Why didn't we think of this before? Take advantage of these individuals who are trained. And because they're in the Bloom program, they actually had to go through a 9-step application, which was really arduous for them to go through, but we only want people who want to go through the arduous process to come in and be offering the Bloom program. So in that discussion, it kind of got leaked out. Oh, by the way, I stopped taking my thyroid pill. You know about hypothyroidism. It's a really common illness. But if you don't take your thyroid pill, it's fatal. So you need to take your thyroid pill. It's very gradually fatal, but it's fatal if you don't have thyroxine floating around in your body. It's fatal. So the pharmacist was the one to find out that the person was not taking their thyroxine pill. And she tried to figure out, well, what's going on here? And so through that process, coming into the program, they're working on helping her depression. So now, is it a chicken or egg? If you have thyroid problems causing hypothyroidism, you can experience depression, or you can present like you have depression, but it's actually a medically induced cause of depressive features. Or you can have both. Or maybe the depression, where she said, I'm not going to bother taking my other pills. Right? Who know? I don't know the answer. It was a really short email. But that's what the program is for. And I don't think if that program didn't exist for that woman, that would have been caught. So what we see the program as being is an extra set of eyes and ears. Now the pharmacist is already an extra set of eyes and ears and is already doing good things. But we've formalized those good things with the program. We formalized that this is going down on paper. I have a file for you, and I expect you to take advantage of me. I expect you to call me when you have questions. I expect you to drop in when you need to. And let's set up appointments as well. And you should expect me to be in good communications with those who support you, your health providers, or a family member. And I have it on paper who I'm allowed to speak to. So I'm not allowed to call your brother, but I am allowed to call your mother if I'm concerned about you, or if you've forgotten something, or if I haven't seen you in a while and you haven't picked up your prescription. Because it's all about confidentiality, but it's also about support for you. And pharmacists have to follow the exact same privacy rules as any other healthcare provider. And they do. But they do it by saying, I'm not allowed to talk to anybody sometimes. But this helps to open it up so that pharmacists are within that circle of support or circle of care, just like everybody else is, formally in it, stated, on paper. And they have documented who else is in it for you.
I'm just wondering how the pharmacists themselves are seeing their role, or, how they're feeling themselves being part of this. It must feel good. I mean, what kind of responses are you
Well,
getting
I think, invite me back in a year. You might do that anyway.
Oh,
Maybe.
But our evaluation has two phases. It has the interim report, which is ultimately the most important report, because I'm hoping that we will extend our funding. And the interim report will be the report that decides that. Because our final, can you turn that off? Our final report will be kind of too late. The funding will be ended, and we'll go in and say, okay, can you look this over and get back to us? And that doesn't tend to create momentum. So our interim report will be hopefully done by midsummer, and I'll be able to say what are the experiences of pharmacists, patients, family members, physicians, support groups, NGOs, and so on. Everybody who really is an important stakeholder will be part of the evaluation. So I can give you a few anecdotes, but I know it's both. So I've done a couple of road trips. One was to our Antigonish and Cape Breton Bloom Program pharmacies. And they're all really wanting this program to work, and they're all really busy. So this is new for them. They have to figure out, how do I get this to work for me in my pharmacy? So two pharmacies in Cape Breton, it's humming. So the pharmacists running it are, I think the communities see them as pharmacists with great big hearts, and they're already there, but they're also well organized, and they're also well connected to the physicians. So that part of the building wasn't as steep for them. So I think those are critical parts. Your mind and your heart's in it, you're well organized, you're already connected to your community, and you have good, strong relations with the other health providers. And that, I think, is critical to it working. And for other pharmacies, it might be really busy, and you might not have all of those other things going on, and they're still wanting it to work. So when I went and did my roadshow, all of a sudden they had much more success because they needed a boost, And it was summer. You do other things.
A question from online from Anita. As it seems now, there's been a shift in responsibilities and job descriptions for persons employed in the pharmacy. Would it allow the pharmacist to be more so a clinician doc type to help close the gap in mental health resources?
Yeah, I think that's the idea. So the shift that you may be talking about, Anita, and maybe you could write back and tell me if we're on the same wavelength here, is they're in a pharmacy dispensary. So at the back of the pharmacy, usually there's a couple of folks working there. There's a pharmacist, and then there's a pharmacy
Technician.
See, now, I wanted you to say both words, assistant and technician. There's both. So this is the shift. So moving towards regulated pharmacy technicians, where they have to go to school and get the diploma of a pharmacy technician. And if they get that, they can actually do more than the assistant. Almost like, you've got your dentist, and then the dental hygienist, and then the dental assistant, sort of different roles for different people. And with a technician, the pharmacist will therefore not have to do the technical work as much, the dispensing work, which would give them more time to be doing what I think should be the core work of a pharmacist. And we challenge, some of our pharmacists, or we challenge some of our students by saying, if you got a job in a pharmacy where you have to do zero technical work, looking at a prescription, entering it into the computer, figuring out the insurance claims, getting the right pills into the right bottles with the right labels, making sure all of that labeling is done correctly. If you didn't have to do any of that, what would you do? What would be your job as a pharmacist? And some of them go, my job would be the best goddamn job I can imagine. And others say, no, I need to be involved in the technical work because the technical work uses my clinical knowledge. I can see 4 medications all together. I go, those ones are not a good combination. But the pharmacist who's doing the clinical work will also have the profile. Just like a physician has a patient's profile and says, okay, I don't have to see the pills to do it. So there's some people that say, no, I see my clinical work in the technical stuff. And others say, I can do my clinical work just as well without actually being embroiled with some of this technical stuff. Now you can imagine where you're a pharmacist in a small pharmacy in a small town, where you're the only one employed because there's not enough revenue to have those 3 people all working at once. What if it's in the evening? It's just you. So you have to be the pharmacy assistant and the pharmacy technician and the cashier. Oh, is there any time to be the clinician? So it's a very big challenge in the world of pharmacy to turn pharmacists away from being technicians and into maximizing their clinical contributions. So we're doing what we can with this program, and I think it's designed well and has great intentions and great safeguards to make sure it's working and so on and so forth. But uptake is challenging on all sorts of fronts. And that's why, my role is as much as a cheerleader, as a pusher, as a problem solver, and so on. So, any questions or other thoughts around the Bloom program and what it is?
You mentioned about that there is a group of people who work in the Bloom's program. So you're a pharmacist, you're a psychiatrist, you're a physician. Now, how do they look at that? Because the psychiatrist doesn't think the pharmacist is stepping over the boundaries and telling my patient that you should stay off this medication or to reduce the medication.
Yeah.
So isn't there a conflict?
So that concern exists for pharmacists working in the Bloom program or not working in the Bloom program. So it's really important that everybody understands what the pharmacist does in the Bloom program is part of the standards of practice for all pharmacists. So if a pharmacist is saying, I don't think you should be taking that, they should say it whether they're in the Bloom program or not. So if you are prescribed 2 medications and one is clearly going to cause problems with the other one, it's my duty to say I have a concern about going forward. Here's the basis of my concern, and I'm going to call your physician. It's got nothing to do with the Bloom program.
Mm-hmm.
So what we hope is that what pharmacists are doing is identifying medication-related issues and working with the individuals and their team collaboratively in concert so that what we're doing is in support of each other. So the example that I gave you was the woman who is not doing well with her antidepressant.
You also mentioned earlier that there should be time to wean off patients from medication. And there's a lot of literature out there, especially we talk about here, is mental health issues, that we prescribe so much medication, there's nothing for the patients to fall back on.
Yeah.
Any cognitive therapy.
Yep.
And it's a big push, in the States and other provinces, but it's next to nothing in Nova Scotia.
Yeah.
And we have talked to our son psychiatrist many times. I don't have time. No. He sees him every 6 months. He used to see him every year. Then he had a relapse.
Mm-hmm.
And to find time to see those psychiatrists twice a week, Tuesday, Wednesday, rest of, if he has a problem during the week, you can't see.
Yeah.
You run to the hospital.
Yeah. And this is why I think there was a mental health and addiction strategy, because people recognize that for a very long time as a huge hole in our system. And it continues to be a huge hole. So this strategy's been done and some of the ideas have come up, but to solve that problem is very time consuming and costly. So you mentioned the US. The NHS in England has made a huge push on making evidence-based psychotherapeutic treatments available to the English and Welsh public. And so apparently in England, Wales, and in Australia as well, it's become a really popular new program for people coming out of high school. What do you want to be? Well, I want to actually be a therapist because there's going to be a lot of jobs. But here, that's not happening. So I mentioned I'm on a national board to do with kind of the safe and appropriate use of medications in the elderly. And we just had a teleconference about that, and I was talking about we can't take away sleeping pills without an alternative. Because if I say, well, let's tell the family doctors and the pharmacists to help people not start on or stop taking their sleeping pills. What actually happens, because this has happened in many places in the world, is, all right, people have heard of Imovane or Zopiclone or lorazepam or Ativan, the really commonly used ones. If I say, you can't use those anymore, so, well, people go, okay, I won't use those. Okay, how about a little trazodone then? And the prescription will just change to a different kind of sleeping pill. Or how about a little bit of quetiapine? It's a sleeping pill antipsychotic. So people just move away. So it's really important for people like me and others to think, when we say we want to adjust what goes on the prescription pad, we need to say there needs to be something as easy to access. Because imagine how easy it is. You come in and you say a few things, and right away you solve the problem by taking out a piece of paper that's got a few set lines on it, and just go down, there's a little fabulous spot. They know what this piece of paper does, and then you walk out with a bottle of pills. Like, how easy is that? Your problem is solved, quote unquote, is solved within a half an hour. Compared to CBT. Well, I don't really know who offers CBT around here. I could look into it. Just give me the prescription.
Even to find, ask your doctor if you can have a second opinion.
Mm-hmm.
Because, in my son's case, for the last 16 years, he has been on the same medication, clozapine,
Mm-hmm.
and the side effects of clozapine over the years, what it does to a person's body.
Mm-hmm.
Can't take him off. There's nothing else.
Yeah.
And
Yeah.
it's very frustrating for parents to see.
Yeah. Well, it's frustrating, I think, in lots of ways. One is it's frustrating because there's good evidence that, I don't know if your son has schizophrenia, but he's on clozapine, so it's a suggestion. That CBT for people with schizophrenia can be quite profound. It's an evidence-based therapy.
Because there's nothing available to you.
That's what I'm saying. So you can say it's evidence-based, but it's not accessible. So what's the value of having it? So I know you guys are strong advocates. You don't just come here to sit here and listen and get frustrated. You're also very strong advocates. And I do my best, and I think we all need to do our best to make sure that the people down the hill closer to the water know that a critical missing link is access to well-qualified individuals who can provide cognitive behavioral therapy to people with serious mental illness. So you can provide it to other people, but we need people who also have serious mental illness to have access to both medications and therapy. Another hand from.
Thank you.
From online from Rochelle, question. My son is on 7.5 milligrams olanzapine and 20 milligrams citalopram. One of his eyes shifts over to the side at times. I noticed that happens since he's on meds. Could the meds cause this? And if so, is there a fix?
By that description, it's not an obvious thing. So we did talk about eyes being fixed up. And what she's describing isn't a side effect that I can think of associated with either one of those medications. I would definitely need to ask him or have the family physician or the prescribing psychiatrist ask about that to try and determine whether this is a medication-related side effect. It's a straightforward thing to ask, but sometimes asking a straightforward question in the middle of a patient-doctor meeting is not so straightforward. So the best that I could recommend is have her or her son write it down and go in and just say, here's my question. I'll give you the piece of paper or I'll say it out loud. Okay, and see if you can get a straight answer from that.
And another question was, could Dr. Gardner speak to the prescribing of clonazepam to seniors and young people?
So I think, from that question, I'm guessing that it's to do with the concern around the use of benzodiazepines. So clonazepam is a anti-anxiety medication in the class called benzodiazepine. Now we have a lot of benzodiazepines. The more familiar ones to us, the one that everybody knows by brand name is Valium. So if I say Valium, you think back to the 1970s advertisements, which was, anybody remember the little ditty, Mother's Little Helpers?
Oh, yes.
Oh, I thought that was the Rolling Stones.
They used a different kind of Mother's Little Helpers. So I want people to understand the class of medications. So Valium, which is diazepam, we use it all the time for very legitimate medical reasons. Lorazepam, which is Ativan, also very well known, probably Nova Scotia's #1 anti-anxiety, sedative, hypnotic, sleeping pill, whatever. It gets used for different reasons. But there's, a list of 10 or 15 of them in that class. And related to that class is Imavane and Zopiclone. So they all work through the same mechanism, which is to increase our brain's GABA. So GABA is a neurotransmitter that relaxes and helps people sleep. So it promotes relaxation, it reduces anxiety or worry, it helps bring on sleep. So clonazepam is one of those. Now, what I like about clonazepam is you don't need to take it a lot. You take it twice a day. For some of the benzodiazepines, you'd have to take it 3 times a day or 4 times a day. So it has some advantages. But all the benzodiazepines, whether we're talking about clonazepam, which is the specific question, or diazepam or Valium, or Ativan, Nova Scotia's #1 at the moment, or Zopiclone, Imavane, the #1 sleeping pill. In the elderly, we have to think about safety. #1 issue is safety. So I'll tell you about the risks. The biggest and most profound risk is falls. So these medications are associated with an increased risk of falls. Now, a lot of studies have been done, and they sort of bring in the group of people we will study. It's usually healthcare databases, so it's not actual people coming in to study, but it's, you look at the database over the last 10 or 20 years to find out who got the drug, and then you look at the database and say how many of those people fell and had to go to hospital, or how many people had to go to hospital and have a fracture repaired. And so what they find is that people are at risk of going to hospital because of a fall or going to hospital because of a fracture at 2 to 3 times the rate if you're taking those medications. Now, everybody here should say, oh, that's not too high. Like, I've been walking around for the last 3 years and I haven't fallen and broken anything. What's the, if you increase my risk by 2 to 3 times, I probably still wouldn't fall and break something. So if your risk is 5%, 1 in 20 in the next year of falling, what would be your new risk if it's increased 2 to 3 times? Everybody's saying 10 to 15%?
Yeah.
Right? So it's still not likely to happen. It's more likely not to happen than to happen. Okay, but you're young and agile. Your chances of falling and fracturing are low. But what about if your risk is 15%, 20%? You know who that is? That's people in their 80s. So if you're in your 80s and you're prescribed a sleeping pill, you've dramatically increased your chance of falling or having an injury. Now, if you don't have an injury, is that okay? No. If you fall when you're 82, living alone, what happens to you? You say, I better not do that anymore because I was so scared because of that fall. So what were you doing? Well, I went out of my house and I went down the street because I like to get a little bit of exercise. And I know the bad weather's coming, but I still do it. I'm feeling pretty good about myself. But now that that's happened, what are you going to do? You're not going to do that. And that's going to take away your sense of independence or your actual independence. It'll isolate you, and it'll have a negative effect on yourself physically and mentally. So these medications are associated with falls and fractures and isolation and depression and anxiety and so on. So that's just the elderly that I was talking about.
The follow-up question about clonazepam. Does it affect memory, and how would it work in someone who has ADD?
Yeah, maybe you can ask a question. Over what period of time? Because short to intermediate use of any benzodiazepine is not considered to cause problems with memory, and they're not treatments of ADHD or ADD. They're not known to help. They're known not to help, if you will. But people with ADD or ADHD have one specific problem, which is sleep problems. Now, the sleep problem can be caused by the illness. So people can have difficulty sleeping because of untreated symptoms of ADHD. Or they can have problems with sleep, insomnia, because of very effectively treated ADHD. So the treatment of ADHD is most commonly a psychostimulant, something that stimulates your brain to be able to focus. Without that stimulation, you're not able to focus. But when you stimulate your brain, you can also stimulate it a little bit too far into the evening and have troubles falling asleep. So sometimes medications are given to treat the illness-related insomnia or to treat the medication-induced insomnia. The first line treatment of insomnia for somebody with ADHD is something that I would recommend is melatonin. So people have heard of melatonin. It's something that our brain, our pineal gland in our brain actually produces, and it coordinates our circadian rhythm. So when the sun starts to set, all sorts of chemicals are released because melatonin triggers this process to say it's time to settle down. The body starts to cool down, and the eyes start to get droopy, and the sleep drive goes up, and that's coordinated by melatonin. And then in the morning, melatonin says, oh, I can tell the sun's waking up because it's triggered by sunlight, and it changes what hormones are released towards wakefulness during the day. So melatonin is a sleep regulator, and it's actually been studied in a couple of good little studies of managing sleep problems in young people, children with ADHD. So it would really depend on what clonazepam was being prescribed for in a young person.
So the response on this is that the person has ADD themselves online, and taking only clonazepam for anxiety, and it's not going well.
Okay. So the not going well could be for lots of reasons, but if it's not helping with anxiety, the first line treatment for anxiety is an antidepressant. Some of you may have heard me say this before, but there's a class of medications called antidepressants that are better at treating something other than depression, which is anxiety. But they're called antidepressants, but they're better at treating anxiety. Did everybody stick with me on that? So what should they have called them?
Anti-anxiety.
Yeah, but you can't go back in time, right? So back in the 50s and 60s, a whole bunch of antidepressants came to market to treat depression. And later it was identified that for people who don't have depression but have quite severe anxiety, they're damn good. They're even better than they are in the treatment of depression. And then the new SSRIs came along, Prozac and Paxil and Zoloft and so on. And they said, well, we know from the history of the other antidepressants that these medications are probably going to be good for anxiety. And they were found to be actually quite good for anxiety and, okay for depression. But they are now indicated for all of the anxiety disorders and for depression. So for people who have anxiety, a severe anxiety with sort of a disabling symptoms preventing your functioning, your day-to-day kind of functioning, then we should talk about medications. And the first medication that people often get is something like clonazepam. Take it when you need it. But it doesn't actually, fix the problem. And for people who live with anxiety on a daily basis, they go to work or school and they just fake their way through it saying, I'm holding it together. And by the time school's over, they get home and they just completely fall apart because they're so fatigued They're so absolutely drained from trying to just keep themselves contained. That's when a medication like citalopram, which is a SSRI, which is a very commonly used anti-anxiety antidepressant, or S-citalopram, its close cousin, but all of the most commonly prescribed antidepressants these days are quite effective. Now, they're not always effective, because I said at the start, very often you go down dead ends, and you have to keep changing courses. So, giving feedback to this individual,
No, this is several people are interested. In this
Oh,
question.
okay. So it's just a reminder that if you go on a pharmacotherapy course, you have to work closely with your prescriber and hopefully closely with your pharmacist to say, you know, what dose, should we keep pushing it, should we give up on it, am I doing better in the timeline you would expect me to be doing better, so that we keep going with it, or give up, or add things, or switch things.
So what are the side effects of SLESA?
So, Celexa?
Yeah.
All right. So it could take a little while, but I'll start from the top. The most common side effect of Celexa, which is an SSRI, so my answer applies to all the SSRIs.
Which are what?
So SSRIs are selective serotonin reuptake inhibitor antidepressants. So the popular ones are Prozac, which is fluoxetine, Paxil or paroxetine. Celexa is citalopram. S-citalopram is, what's its brand name? S-citalopram, Celexa. It'll come to me.
Cipralex.
Cipralex, thanks. What am I missing? Oh, sertraline is Zoloft. So there's kind of a family of the most commonly prescribed antidepressants called the SSRIs. And then there's a kissing cousin family called the SNRIs. Don't forget the N, it's SNRIs. S stands for serotonin, and N stands for noradrenaline. So it's a family of antidepressants that targets both serotonin and noradrenaline. So the most commonly used one that people have heard of is Effexor, venlafaxine, and then less commonly something called duloxetine.
Where does Belbucan go in there?
It's not an SSRI and it's not an SNRI, it's an NDRI. So it has nothing to do with serotonin. So I'm glad you asked that. So when I get back to answering the side effects, I can help you do a little pharmacology, becoming a little pharmacologist. So when there's an S, SSRI or SNRI, and this is how I teach the medical students and the pharmacy students, because it's hard to memorize each drug and its side effects, but if you can learn some basic rules based on the pharmacology. When there's an S, you know, that's serotonin reuptake inhibition, and everybody goes, yeah, okay, get that. What can you immediately know as a side effect? You know, I don't know. I said, well, how do you know these things? Well, I guess I just look at the list and I try to memorize it. I go, yeah, who can do that? That's too hard. So serotonin coordinates an awful lot of stuff. It coordinates sleep, appetite, sex drive, as three obvious things that it's important in. Mood regulation. That's why we try to manipulate it related to depression. But what did I say? Sleep. So people can, because it's got an S in that family name, SSRI, it can actually disrupt sleep problems. Or it can improve sleep problems. But it can affect sleep. It's hard to know what it's going to do in the individual. The next thing I said was appetite.
Mm-hmm.
Okay, so what can it do? Our gastrointestinal tract is full of serotonin receptors. And if there's too much serotonin there, we're nauseous. So the most common early side effect of Celexa is nausea and sometimes vomiting. So that's, the good news is if you have it, it often goes away with continued use. But who wants to continue it if you feel so nauseous you're vomiting? So very often people stop it within the first few days or the first couple of weeks because of that side effect. Sex drive. Here's the bad news. So Celexa and those other SSRIs and the SNRIs can cause your sex drive to go down and your ability for successful sex to go down. So, and it can affect men's performance and women's performance, so preparation for sex. Not just interest in sex, but preparation for sex and the ability to climax. So, just imagine that. A pill to help you with depression that causes you to fail sexually. That can be pretty devastating when you're struggling with your self-worth. You're feeling maybe not sure if you're feeling hopeless anymore, and then something like that happens. So it's a really important side effect for us to talk about with individuals so they know it's not you, it's not your illness, it's not physically something wrong with your body, it's the medication. So the rate of nausea is probably about a third of people will experience that. And unfortunately, that's about the rate, maybe a little higher, of the sexual side effects as well. And less than that, somewhere between around 20%, will describe some sort of change in their sleep. Sometimes it's an improvement, and sometimes it's insomnia, this medication, I can't sleep. Also related to those medications is a sense of restlessness. Now, not everybody gets it, but people who have anxiety, especially panic disorder, people who have experienced panic attacks, when they first start taking Celexa, can experience a worsening of their anxiety. And so we always say, for that group of individuals, start with a very low dose and gradually increase it. But for other people, we don't have to start with a low dose. So that's kind of a taste of some of the side effects. Less common ones are jaw clenching. So there's a few less common ones, of course, but those are the main early onset, troublesome, problematic ones.
I have a question.
Sure.
With the Bloom program, as far as we're concerned, because we are mostly dealing with schizophrenia.
Yeah.
Do the pharmacists go through any kind of additional training for dealing with that type of mental illness, or they just know what they're doing from the very get-go?
Well, if they've graduated in the last, how many cohorts did I say I taught?
18.
They hopefully will remember what I taught them.
Mhm.
So what I teach you is, a part of what I would be teaching them, and they would be expected to know what they're talking about the psychosocial components of the illness as well as the pharmacotherapeutic components of the illness. But when you haven't used that part of your brain, when you've graduated and you're not really applying it in a clinical way, no matter who you are, you'll lose it. So we do have, as pharmacists, the expectations that we will maintain our competency through different forms and methods of continuing education, whether it's to do with infectious diseases, mental illness, cardiovascular disease. And you will see some pharmacists will gravitate towards some areas more than others. So the ones who have come into the Bloom program, I think, gravitate towards knowing about mental illness and the medications for mental illness, maybe a little better than on average other pharmacists. I wouldn't just say everyone is better. In the training of the program, though, we focus on identifying people's needs. So, if you ask me a question that's really specific about clozapine, I might be able to answer it because I'm a specialist in that area. If you ask that same question to a family doctor, maybe not have an answer for you. And the average pharmacist specifically might not have the answer for it. Pharmacists are good at looking into things and they have good skills in that area. But if it's a pharmacist in the area of the Bloom program, they have me as a resource, and they have each other as resources. And they also have in their pharmacies a better resource library. So we say you can't be in the Bloom program unless you have additional resources sort of behind the counter in the pharmacy that support your psychopharmacologic knowledge. And you also have to have a library that's available to the public that's focused on mental health and addictions resources. Not necessarily about pills, but about what's in your neighborhood, or what are these illnesses and where do you go and learn about them. And our website can help with that kind of thing. So we don't try to make it that you need to be the expert in the therapeutics. We try to make it that you are able to care for those individuals in your community. And you won't be able to answer all their questions the first time you hear it, but your role is to help them achieve their needs. And if answering a question that you don't have an answer to is one step towards helping achieve those needs, then that pharmacist will do that kind of thing. There are pre-readings, so we give them a quiz before they get involved at all. So I have selected a really broad area of readings: diagnostic stuff, problems with the use of psychotropic drugs in North America, Canadian and American data, and what are some of the problems and how we're using these medications. Competence, how you need to maintain your competence in these kind of areas, and then a few other things like working in teams and so on. So a lot of readings covering a broad range. And they have to do this pop quiz before they do all the readings and before they do all the training and before they do the implementation of the program, and then they do it a month later. So again, when I come back, I'll tell you if any of it made a difference in the pop quiz. So I think, we are trying to have it so that they are better listeners and able to meet the needs of the individuals. So that's all I can really say.
I've seen some mention on the internet about a test to figure out what would be the best medication for something like schizophrenia. Can you speak to that?
So that topic, what you saw, that could have come up anywhere. I'm not sure where that would come up, but from my side of things, for the last 10 years, probably more, there's sort of this new area of research, and it's huge, and it's not just in schizophrenia, it's in all sorts of disease areas or therapeutic areas, and it's called personalized medicine. So if you Google personalized medicine schizophrenia, you'll probably have a lot of hits that relate to this. And the idea is, I get some information about you from a genetic level to determine if I can better identify what medications you will respond to or tolerate, or both, up front, so I don't have to go through the process of trial and error the way we currently do it. So we're not very far along. So claims of, we've now got some data that suggests that we can identify people with schizophrenia who are responders to risperidone and not olanzapine, or quetiapine and not ziprasidone, or something along those lines. We're not there yet. So what the tests do is they do identify people genetically, and they do that accurately. Now, sometimes they make a big deal out of that. This test can tell me if you are recessive or dominant in the expression of this gene, and this gene has been associated with intolerance to some of the antipsychotics. So I can tell you which one you are. And you go, oh, that's amazing. That's exactly what we need to know. And then I would say, okay, if I know that, does that actually lead to better outcomes for the individuals tested? And that's the critical question. If knowing that, does that actually change the dosing or change the selection? And when we look 6 months down the road for the people who had the genetic test compared to the people who just went through the regular way of being treated, is one group better off than the other? We need those studies. And so far the studies that have been done haven't gotten us ahead yet. But it's really complex. So, one area is how quickly we metabolize medications. So I was teaching the psychiatry residents this the other day. Our livers, so when we absorb a medication, it gets absorbed mostly from the small intestine. So the stomach crunches it all up, and then eventually gets liquefied, and then the drug's kind of in solution. And then we absorb it into the bloodstream from the small intestine. And you know where it goes? Right from there, it can't go anywhere else. There's only one place to go. It's to the liver. And the liver is the organ in our body that's responsible for metabolizing all sorts of chemicals that we come in contact with. So drugs included. But we're swallowing foods and enzymes and proteins that our liver takes care of all the time. So when it goes into the liver, it's broken down by, drugs are broken down by, a bunch of really well-known enzymes that metabolize them. And we know that some people don't have some of those enzymes. And some people have 13 copies of the genes that make those enzymes, meaning that they metabolize it way faster than somebody else. So around this room, there will be some of you who are missing a key metabolic enzyme. And we don't know that because we don't do the blood tests. But you know it because you go, I'm really sensitive to medication. Other people take them, but I'm really sensitive. And we go, oh yeah, it's all in your head. No, it's in my liver. My liver doesn't have the enzyme to actually break it down. And then other people go, well, actually, I can tolerate anything. And they have those enzymes that have 13 genetic copies of it, and they metabolize it so quickly. So I asked the psychiatry residents, so have you ever had a patient who is sensitive to everything or not responsive to anything? And have you ever thought, maybe it's pharmacokinetics, how quickly the body gets rid of the drug, and not to do with something a little bit more complex than that? And they go, I don't think that way. I go, well, maybe you should. Now, who is more likely to have multiple copies, or who is more likely to have none of that? And I showed them kind of this world map of different cultural groups to show who genetically is predisposed to really fast elimination, medium, kind of slow, or really slow. So knowing that kind of stuff, but still we don't use that in our clinical practice to help us figure out what dose of medication. We just do it clinically. How you doing? Oh, you're not tolerating it. Whoa, maybe I gave you too much, or hey, I gave you more than the maximum dose and you're still not responsive. So currently we're still doing it kind of old school, seeing how you do, and you want a prescriber and a pharmacist and a nurse to be really good at assessing how you do and making dosage changes based on that kind of feedback. And that's where we get into this kind of tug of war, if you will. In clinical practice, people say, stop treating me like a chemistry set. Right? You and your questions about the medications, that's all you ever ask me about is the medications. You don't ask me about all the other things that are important. Part of it's necessary to figure out what's the right dose or the right medication, and it's the right dose of that. And that can be a difficult challenge that requires a lot of evaluation and follow-up. And then sometimes you get into such a rut, you just say, that's all we ever talk about. Well, let's not ever talk about anything else that's important to you.
Thank you.
I need a moderator here.
Just specifically to do with this, is this why the clozapine levels could vary because the person metabolizes differently?
Oh, for sure. Clozapine, yep.
So if you are sensitive to everything, would that mean that your clozapine levels would show as higher?
That would be what we would predict. It's way more complex though, because we have certain other gene predicted receptors. So for example, there's a whole bunch of different types of serotonin receptors, and there's subtypes of specific receptors depending on your genetics. And if you have a certain type, you might be very sensitive, experience side effects compared to if you don't have that type. So it's not just pharmacokinetics, it's also pharmacodynamics. So the interaction between the drug and the specific receptor might correlate with tolerability or effectiveness. And it's not to do with how much is in your bloodstream at any given time. Sometimes, so that I'm giving you answers that say, I would predict it might be that it's because you don't eliminate it as fast as other people and therefore you have high levels. But I should see a whole bunch of side effects that are associated with that drug, right? So that might help me explain that. But if it's just one specific intolerance and you're not getting all the other side effects, then it might be more of a pharmacodynamic to do with the receptors that you have, that drug binds to.
Doctors look at that?
The only thing that you do clinically is clozapine drug levels, but we can't actually, in clinical practice, do a little snippet of your DNA to figure out which enzymes you have, because it hasn't been found to be strongly enough associated, and the tests aren't cheap enough and available enough to do.
Do you wanna go first?
No, you go ahead.
I just with so many of the drugs that deal with schizophrenia, they say, oftentimes it takes 6 months before you know whether or not it's going to work. So it takes that long. And if people are having, bad side effects, how do you deal with that?
Yeah, it's a tough one. Antipsychotics work faster than we often talk about. It's kind of like trajectories. So if you see things going in the right direction with the right trajectory, you're going, good, we're going to keep it going. We're not saying that's it today, that's the best that's going to happen, but things are all moving in the right direction. And you can imagine that if some of the core symptoms have improved in the first 2 to 4 weeks to some degree, then that improvement will open doors that haven't been opened for a while. So you get to be more independent, you get to do things you didn't do before, you build your self-esteem, and you get practiced at things that you haven't done. And then 2 months down the road or 3 months down the road, other opportunities come along. And you say, oh, I'm not ready for that. And then another month goes by and you go, I am ready for that. And so we talk about positive symptoms and negative symptoms of schizophrenia. And we need opportunities for those kind of things to be rehabilitated, if you will. So the antipsychotics are kind of paving the way for other things to kick in that are not to do with the core beneficial effects of an antipsychotic. So whenever people say, give it 6 months, I think in one way they're just kind of saying, let's just sit on, the little bit of optimism that we're seeing here because some things are improving. But don't anticipate, dramatic changes next week or the week after or the week after. But let's take 6 months or even a year and try to reflect accurately on how things were in the first couple of days or the first week or the first month of this medication. When it comes to clozapine, we're very reluctant to give up early on it unless side effects are particularly bad, because that's what people have found, this sort of longer story where we see gradual improvements continuing along that weren't expected at the 1 month mark or 2 month marks. And it's also pretty horrific in terms of side effects in the early going with clozapine. People just don't like being on it. So we have to be really cautious. So it might end up being a rather low dose, maybe a not so effective dose for quite a long time when you're gradually building the dose up over time and managing the side effects that can come along with that dosage increase. With the other medications, all other antipsychotics, the story is kind of the same, just a little less optimistic because clozapine is more effective for the average person taking it compared to the average person taking another antipsychotic. But the corollary, or the opposite, is 1 month of taking an antipsychotic and seeing zero improvement. Like if it's kind of going, oh, you're on it, and things are really bad. And 1 month later, you're on a full dose, and the exact same amount of illness is there.
So even after 1 month?
Yeah, you probably, like it's a trajectory thing, right? Like I think I'm predicting the future here, and it's going to look the same. But if it's, like this, but it's hard to see, and that's where we need really close, accurate assessments, because it doesn't go like that. It goes like this. Optimistic day, yeah, not so good, and then down. Can you tell which way my trajectory is going? It's hard, isn't it? And when we don't have good communications and good documentation of these kind of things, or good scales to establish, is the average of that up and down line that I was doing, is the average a gradual increase? What can be concerning is 2 or 3 bad days right before you see the doctor. Oh, it's not going well. You know, everybody just has that recency effect, that memory of the last few days. She did this yesterday, he did that yesterday. And it's not necessarily you guys reporting, sometimes it's inpatients. So the doctor has Monday morning rounds or Friday morning rounds. How's it been going? Well, last night he was screaming at somebody else. Okay, but we have to do something about that. But other than that, you know, it was going really good. And the screaming at somebody else was because something really did happen. But we didn't know that because the 2 people in the altercation didn't really reveal all that information. So it's tough. And sometimes we make bad decisions based on inadequate information. So there needs to be some sort of systematic evaluation, and I don't think in psychiatry we do it as well as we could do it.
David, can you talk a little bit about the long-acting injectable forms of antipsychotics? Because I know as a person supporting a son with schizophrenia, I had really little understanding of it. It seemed in my head that it was kind of like only if all else failed, or only if we could find a way to convince the patient that this was a good, I mean, I had all kinds of misconceptions
Right.
around it. I'm not sure I'm all that much better informed now.
Right.
And I also thought that it was an either-or thing. You either took it,
Right.
you know, intravenously or intramuscularly, or you took orals, and now I know that.
Sometimes we overlap. Yeah.
Right. So
Yeah.
can you talk a little
Sure.
bit about what we know about them?
Yep. So, and I'll bring it back to clozapine. So clozapine gets this strange reputation that I tried to get rid of because people say clozapine's the last resort. So you were kind of saying, you know, like, what's after clozapine? So what I would much rather have as clozapine, and I'll apply this in a second to the long-acting, clozapine's reputation as, I would want people to call it, now when I say people, I'm thinking all of us, but you know, very much so clinicians, the psychiatrists. I would want them to say, 3rd time lucky with clozapine. Because clozapine can't be given in Canada until 2 other agents fail. But clozapine's more effective. So why can't we just give it right away? Because if we wait until you get to clozapine, you've lost a lot. What happens before clozapine? Well, you get these other drugs that have a slightly less optimistic prognosis. You know, it's great if you respond to risperidone. That's awesome. But there was a slightly better chance that you would have responded better to clozapine had you been given clozapine first off. And the same thing for olanzapine or quetiapine and other things. But you have to wait. And what happens in reality is waiting means a long time. Because you don't want to give up on something. So we just argued that, you know, you should take months and months. And then somebody goes, well, they kind of did okay on the olanzapine except for the weight gain. And so let's, you know, see if we can go with a lower dose. Or let's try something else and go, geez, you know, this is now 3 years down the road. And somebody like me goes, let's talk about clozapine. Well, I don't think the family's ready for that. They said that they don't want to talk about clozapine. Or I mentioned it to the individual, the patient, and she doesn't want to talk about clozapine. So clozapine's got a reputation. You can't get through it.
It does have a reputation.
It does. And my reputation is, damn, it should be the first one because it's the best. Now, it fails a lot. So I know some people are sitting here going, listen to him talking about clozapine. I know it fails a lot, but they all fail a lot. So I've been convinced because I've seen some people do really well. And I know I've also seen some people do really badly on clozapine. But the successes are pretty remarkable. Taking somebody from being basically hospitalized for what would be the most of their life to being somebody who shakes my hand on the street on their way to the job. You know, that's the you know, the extreme success that clozapine can afford some people. Now, the vast majority of people don't have that tremendous success. They're somewhere in the middle. But I've shown you this before, that here's that normal curve of people's improvement with all the other antipsychotics. Just take that normal curve and move it a little better, closer to perfect. So it's still got a lot of people who don't do well, but there's a few people closer to doing complete response. And the average amount of improvement is improved. So clozapine was identified in the 60s. And then it came to different markets around the world in the 70s, and then it was quickly pulled off the markets because people died. They died because their immune system had failed in a certain way, and they were infected, died of pneumonia and things like that. And it was identified that people's white blood cell count goes dramatically down if taking clozapine. Now, it's not everybody's, it's just a tiny proportion. And so somebody said, oh, while it was on the market, it was really good for some of my patients. Some of the clinicians actually remembered it being better than the rest, just from the clinical use of it. And so there was kind of a big push to do a proper trial of clozapine in sort of a newer age and determine its risk versus its effectiveness. So the big study that came out was by a guy named John Kane, and it got published, I think, in 1988. And to get into the study, if you have schizophrenia, to get into the study, you have to have failed on 2 antipsychotics before. But even that wasn't good enough. They said, well, you got to even prove it to us in the study. So we're going to give you haloperidol, and we're going to give you haloperidol. Now the usual dose is like 10 milligrams. We're going to give you 60. So you're going to get 60 milligrams. And you have to fail on it to stay in the study. So everybody got into the study, got on haloperidol. And if you got better, you're out. Because you don't want to be in the study anymore because you got better. But the people that were still completely unwell said, okay, we'll stop the haloperidol and we'll randomly allocate you to either clozapine or chlorpromazine. The chlorpromazine group, after, I think it was 6 months, so this is pretty long back in the day, 6 months of treatment, the chlorpromazine group, was it 6 months or 6 weeks? Anyway, for a certain period of time, guess what the rate of response was, like had a successful outcome? It was 4%, which is abysmal. But this is a group of individuals who had failed on 3 trials now, including a high dose of haloperidol. And clozapine's rate of the same definition of success was 30%. So there's something weird and wonderful and different about clozapine. And that's what sets clozapine apart. And then a bunch of other studies and then clinical experiences sets clozapine apart. So the other medications. So clozapine should be something we try early because there are people who would live miserably, unwell, if they only try those older medications or the new ones that are not clozapine. We therefore think about when we have a different group of individuals, somebody we're thinking is not reliable for taking their medications by mouth. And that is everybody? No, it's not everybody.
A lot.
But it is a lot of people. It's a very large number of individuals. And if we can have those individuals agree to an injection, it takes away a lot of concerns. Family concerns, clinician concerns, and patient concerns. Sometimes when I'm well, I'm glad I'm on my medicines. I know that I don't like these aspects of them, but the alternative is scary as hell. And I don't like what it does to my life. I don't like what it does to my relationships, and so on and so forth. So I actually appreciate the fact that there's something that when I'm doubting my need for these pills, when I lose my insight, I have something that keeps me from relapsing. And that's the idea of the long-acting injectable. So when should we use them? So there's no sort of absolute rules, and different practitioners will use them quite differently. They're very much more popular as a very common way to treat people with schizophrenia in England. So in England, the rates of long-acting injectable use is very high relative to here. And we're much more like the US, where the rates are extremely low. So the newer agents that are now long-acting have brought back a little bit of a small renaissance, if you will, brought back the idea of using the long-acting injections. And so we have paliperidone, which is every 4 weeks, like every month and we have risperidone, which is every 2 weeks, and brand new is this aripiprazole, which is also a monthly injection, and a new version of aripiprazole, which is Abilify. People know Abilify?
Oh, yes.
Okay, so Abilify is available in the pill, and now it's available in the 1 month injection. And
Are they equally as effective?
Roughly, and I'll talk about that. But Abilify is going to have every 3 month injection. I'm not sure if it's available in the States yet or not. I can't remember it is, but basically 4 injections, and I do this. You know why I do that? Right? 4 injections per year, and the hope is that that will be sufficient for maintaining the kind of response that you get with those medications, which goes back to your question. So, are the long-acting medications a better approach, on average, than the oral form? And that question, I think, is not as clearly answered as you would expect it to be. And the answer, therefore, is it's not so obvious that the long-acting ones have better outcomes than the oral agents.
I'm not looking for better, I'm looking for equal. I don't
Yeah,
want to
I don't think they're
worse.
less, I don't think there's anything to suggest less effective. But I think the hope is that if we can guarantee it's going to be there, because we know that when you come back, we put it inside your muscle. We know you've taken it. Then there's more of that guarantee that you're medicated, and the minute you don't show up for that appointment on that day, we know that you're gradually losing that medication. So the good thing is, when you don't show up, it's not just going to be gone the next day. It's going to be gradually going for the next few days, next few weeks. So it gradually builds up over time, and you get these injections, and it's building, and then you don't show up. It doesn't just go like that. It goes, like 3 months later, you start to have new symptoms. But we've known you haven't come back for those. We've been in touch with you, encouraging you to come back, or we've been in touch with your family.
But for those, I think I have heard, for those who are on the injectable, they like it. One reason is because they don't have to think about their mental illness every
Right.
morning when they
Yeah.
wake up
Yeah.
to take their pills, that
Yeah.
they're mentally ill. They're they can go about their day and their life and not think of it until, oh my God, tomorrow I have a doctor's appointment.
Yeah,
It's much more normalizing.
right. So there can be self-stigma.
Yeah.
You go to your pills and you go, why me?
Yeah.
Or whatever it may be. And some people, you look at that and go, this is my road to wellness. I need to take care of my health. And this is part of me taking care of my health. So it cannot actually act as the opposite. So if you're not looking at that on a daily basis, you're not thinking about your illness, you're going, I don't know, people, I think we all get into bad habits, go, well, I'll just have a little bit more cake, or just have another cookie, and nobody will ever notice, right? So I'll just have another drink, or I'll stay up late, or I won't follow what is good for my mental health by attending to my daily routine and not doing the things that I know that undermine my own mental health. So
That's another way to look at it.
you don't
It's
need
good.
to swallow pills to have that as a primary thing, but sometimes for some people. So it was Carrie Fisher. Everybody knows Carrie Fisher.
I've heard the name.
Star Wars, yeah.
Oh.
Princess Leia.
Oh, okay.
So she's a well-known spokesperson, outspoken about her bipolar disorder and addictions problems for decades and decades. And talks about how fat she is. I'm using her words because of the pills she's been taking and so on. And she takes 5 different kinds every day. She talks about how she finds that centering because it reminds her that she has to take seriously her mental wellness. And it's not just taking the pills, but it's all those other things that help. But I would think the vast majority of people don't have that as a perspective. It's more that I don't have to think about it. I just get my shot and I'm good. Now there is a challenge. With pills, we adjust the dose. Remember I talked a lot about adjusting the dose. And I can adjust the dose relatively frequently. and achieve less of the medication or more of the medication reasonably quickly. When it comes to the long-acting, I can't. If you end up having side effects, I can't take it out. I can't just say stop it for 5 or 7 days and then we'll rethink things and we'll start a new course. It takes weeks to months for it to leave. Or if it's not working sufficiently, that's why we sometimes go into, we'll take the oral medication. Well, it's not working well, so I have delusions and I deny my illness and I'm not going to take the oral ones. So it can be quite a challenge for some people to get back to an effective dose by moving the medication up. So it wouldn't be any better with just an oral approach, but it doesn't solve all problems when it comes to when people have adherence problems.
Is there anything different about one called Invega?
So Invega is paliperidone. Yeah. So Invega and risperidone are really similar. So Risperdal, you heard of that one?
Yeah.
So Risperdal and Invega. So everybody who's ever tried Risperdal has tried Invega. You know why? Because if you take risperidone, which is Risperdal, remember about the liver and the circulation moving it into the liver? Within an hour of your first dose of risperidone, you've absorbed some of it and it's gone to your liver. And the first thing the liver does is take the chemical structure of risperidone and take a double bonded oxygen and add a hydrogen to it. So it hydroxylates one part of the molecule. And guess what? That's Invega. So Invega is just like risperidone in terms of its chemical structure, except for instead of a double bonded oxygen, it's a hydroxyl group. So the manufacturers of risperidone recognized that the most prevalent active metabolite, so it's a metabolite that our body makes, is an effective antipsychotic. So now they make the effective antipsychotic in a pill. So you have risperidone floating around, being an effective antipsychotic, getting metabolized into paliperidone floating around. So everybody who has risperidone is taking 2 active compounds, 2 active medicines. And now you can take just one of those called paliperidone without having to take risperidone. But it's a tiny difference in their chemical structure. So they're ultimately very similar to each other.
And they have the injection.
And they're both injection, but the advantage of Invega is it's monthly instead of every 2 weeks.
Can it cause a person to have stomach problems?
What kind of stomach problems?
Well, in this case, our family member sometimes has a few beers, even though he's on this injectable,
Mm-hmm.
and he will throw up quite easily.
Interesting. I think the answer is possibly. So antipsychotics are actually anti-nauseants. So they work through dopamine, block dopamine. And when you block dopamine in somebody who is nauseous, you reduce their nausea. Or vomiting, you can stop their vomiting. But Invega and some of the other antipsychotics also play around with the serotonin system. And if you remember, I said earlier, serotonin is related to our appetite. And when you play around with it, you can cause nausea. So it's possible that Invega has adjusted his tolerance of certain things that can cause you to vomit. So everybody knows too much beer can cause you to vomit. I didn't teach you guys to say anything with that statement, did I? Right? Okay. So everybody knows.
There might be questions coming in.
Okay. So it's possible that the medication could adjust your sensitivity to that. So there's an easy answer, isn't there?
Well, not so easy if you know what this is.
From my side. Yeah.
I'm just wondering about these antipsychotics, like clozapine. I I'm told that when they work, they always work. And what I'm wondering is there anything that can change that, in other words, if a person is successful on this medication, regardless of how long they're on it,
Yeah.
regardless of how many episodes where they've been off of it,
Yeah.
and to be put back on, it will always perform the same way? Is that?
I don't think I would say it that way. So
In
there's,
other words, does it always work?
no. So clozapine is associated with sometimes abrupt relapses when people stop it. So you're doing well and you stop it abruptly and you have a return of symptoms that's quite dramatic. Will it work equally well when you get back on it? Possibly, yes. But if you do that enough times, you may not have the same response on the 10th time compared to the first time. So this has been seen with clozapine, but it's also been seen with other antipsychotic medications that relapses, the more time that you have been unwell, is associated with affecting your prognosis down the road. So we really encourage people to do what they can to avoid relapsing.
And these drugs are designed to remove symptoms?
Yeah.
In other words, that's how they're determined they're working?
Right.
Because all the symptoms disappear?
Yeah, so that's a good question about how do we determine if an antipsychotic is worth it. And your definition is probably more optimistic than the government's, who says that antipsychotic is safe and effective. So what do we mean by effective? And I'll just give you maybe a couple of examples of response. So we can't do these studies anymore because they're considered unethical. But a long time ago, when we didn't have a lot of options, we were giving people with schizophrenia an active antipsychotic or nothing to see the difference between the two. Now these are called placebo-controlled trials. So if you give me a pill, I can't look at it and know if it's the real thing. It's a purple pill, and it might just have sugar-like ingredients in it, or it actually has haloperidol or one of the earlier, older antipsychotics. And then when we look at how people do, it's pretty dramatic. Maybe 25% of people on placebo have their symptoms go from this high, lots of symptoms, all the way down to here, not zero, but halving their burden of symptoms. So just going into care, you have schizophrenia, but you go into a study where you're getting cared for by people who walk around, in a hospital with questions and sit down with you and see you every week. Just going into care can help your symptoms improve. And getting guidance on, how to adjust things in your life that may help you. So that's maybe 25% of people will have at least a 50% improvement in their symptoms. What about with an active antipsychotic? And it might be something like 40% or 50%. So half of them are getting a half improvement or more. So it's not like the drugs are designed and only the ones that completely eradicate the symptoms get onto the market so that we can use them in our patients. It's the ones that look like they're significantly better than no treatment. But now we can't do those studies. So the new ones that come onto the market are compared to the ones that are already on the market. So if we know the ones that are on the market, half of the time they can help people go from here to here. Well, if the new one comes along and says, well, we can do it 47% of the time we can help you get down to here. It's actually looking a tiny bit less effective, but about the same. So you see how new ones are being compared to the old ones. And other than clozapine, and maybe olanzapine and risperidone, the newest ones we don't think are better than the ones that were on the market. They're about the same, if not a smidgen a little less effective.
Now, when a person gets off the medication and is put back into the hospital, and they're put back on the medication, they're released at a certain point in time when the hospital feels that it's working and the symptoms are gone, right?
But usually we have people discharged when it looks like things are going well, and they're predicted to do well when they're discharged, even though they may still have residual symptoms
You mean that come back?
that have not all gone. So,
Well, I'm,
Sure.
I'm trying to get at something specific. I'm trying to understand something
Sure.
specific so I can give some value to somebody who's struggling with this.
Yeah.
Who doesn't recognize the illness, doesn't want to accept it.
Yeah.
And does take the medication or makes an effort to take the medication, but really doesn't want to and doesn't believe. They're doing it probably because it's the way to find peace
mhm.
and not have to go through all these episodes with doctors, hospitals, police, and so on and so forth. But they're showing symptoms that they didn't show when they were released from hospital, but they're still functioning.
Mhm.
And what I'm trying to determine is medication starting to fail. Are they not taking? I know they're taking it, but are they taking it regularly in
Right.
the right amount?
Right.
Which is it, or how do I
Right.
determine? And at one point, through the hospital episodes, the medication got reduced, which I sort of disagree with, but I'm not an expert.
Yeah.
And the patient who was in the hospital involuntarily, at the moment of his release, I was asked what I thought of his progress, and I,
Right.
from basic, on experience, I said he's probably 85% there.
Right.
And asked what I thought. I mean, I don't know. I'm not.
Sure. It's a tough question.
I would have to say that the medication levels you brought him up to aren't exactly what he was on, or he should be brought up a little bit, and just a logical conclusion, right?
Yep.
So at that point, this patient who was involuntary and in the room with me was asked by the doctor, and the doctor agreed that I may have a point, and asked this person if they wanted to minded having it increased, and he said absolutely not.
Right.
The doctor said okay. So my next question was to the doctor was, well, let's say if they're taking this over a long period of time, will it compensate for that? Will it improve? And they said probably, but it hasn't.
Right. Well, I think you're telling a good example that a lot of people have gone through this struggle, where the issue is the symptoms are still there. And when you get discharged and you're not completely well, you have a higher chance of relapsing.
So what is the person's course of action?
We don't have much choice. So if the person is well enough to be discharged, even though they still have symptoms, if they can make their own decisions, so they're no longer, the doctor can no longer say, you're incapable of making decisions, therefore we're deeming that you must stay in hospital, and so on. But if the person is capable to make decisions, they are not certified anymore, and they will eventually work with that individual who's not certified to be discharged. And if the person says, well, I feel like I'm doing okay, and you say 85% there, the doctor will say, well, I would still like to push the dose up. And you say, I think that's a good idea. And if the patient says no, we can't force it. So all we can do is continue to support that person's wellness by making sure that they're taking what they're willing to take and keeping the door open for increasing the dose with the same kind of discussion as that, well, you're willing to take this medication, what does it do for you? And if you know, if I'm watching you and letting you know if I think there's some symptoms that might be helped, you want to talk about it, you know, like it's really a very thin line to walk along to help that person make the decisions that are in their best interest. And they have to see the reason why it's in their best interest, which can be hard when they don't agree that they have the illness or insight into the illness.
These symptoms were not present after release
Right.
for a period of time.
Right.
Which I guess I'm at a point where I think it's the medication isn't taken regularly.
Yeah.
But you know, I don't stand over the person because that doesn't work, and I'm just more or less an observer, and I just keep an eye on things. But the people that he was put in care of, even though he visits every 3 months with an outpatient's doctor, who won't accept any of my calls, after the 20-minute session, I'm told by this individual that things went well. And I don't know what is said there, so, but I can definitely say, you know, there's more that I think could be done for this person.
Yeah. Yeah, so I'll tell you what, there's 2 thoughts I have, maybe 3, related to that situation. So one is, the illness itself can, I describe it, have a mind of its own. So you can be taking the same medication dose every day after you get discharged and not miss a dose. And the illness is kind of being suppressed. You don't really see the illness so badly, some symptoms. But the medication is doing its job. But underneath this, the illness is kind of having its ups and downs. And one day it just might have a big kind of up and shoot through the effects of the medication. So the medication at this dose is able to suppress the breakthrough of any symptoms. You don't see any of these symptoms because they're all suppressed. But it has a mind of its own, and sometimes it breaks through, even though at that dose. So we would actually say, push the dose up so that you don't see any of the breakthroughs and you stay well. But the patient may say, I definitely don't want you to push the dose up. But another thing can happen is, you're on a given dose, that's probably going to be pretty effective for you, but every now and again you start not taking it. So actually that daily dose is doing this kind of thing, and it's starting to go down. So the illness that has a mind of its own is starting to break through. So once it kind of breaks through, you might stop the medications altogether. So it can be kind of like a runaway horse. Once it gets a little bit of momentum, the illness, the symptoms returning, they can return with a vengeance. And it means another hospitalization. But if the symptoms come through and you catch it in time by increasing the dose, no hospitalization, very little concern overall. So those are the things that make me think, your story makes me think about just sometimes it's not the medication failing, it's the illness doing its own thing. And other times it is the medication failing because the illness is not as well suppressed as it needs to be.
Are you saying that the illness evolves like a disease that's not, it gets worse?
So in long-term studies of people with schizophrenia, there seems to be some people that do have deterioration over time, but the majority of people don't. So there are maybe a subgroup that we can't identify up front that would have that. The vast majority of people have kind of a predictable course over the long haul. And other people actually can kind of, I don't know if the right term is come out of it, but actually can burn, the illness can almost burn out. And in later decades, they seem to be less burdened by the illness itself. So different people say that schizophrenia is one word, but it probably means a whole bunch of underlying illnesses that we're not smart enough to figure out from a genetic basis. One person's schizophrenia might be a very different illness than another person's, but we use the same word.
So in a certain period of time when you say that it may escalate, the illness may escalate it, and the drugs can't suppress it, then
we change drugs or we increase the dose.
But when you say we, how is that done? When I'm the only person that seems to be observing that.
Yeah.
I have no,
I think unfortunately, sometimes it's done after the person has another relapse and gets hospitalized, and a new plan comes up, which is really not ideal. But you said one thing that made me wonder. I think the doctor won't take your phone calls. Right? That's what you said. So, the way privacy legislation goes, and the psychiatrists that I work with will all say the same thing, that care providers, and I'm seeing you as a care provider, may or may not be allowed to know what's going on with the patient. So the doctor cannot necessarily, unless the patient says, oh, you can talk to so-and-so. But if the patient says, no, you can't tell what we talk about in here, that's fine. But most physicians I know would say, if you're the care provider, please feel free to call me and tell me what you're seeing, and I will use that information in my next meeting, or in how I consider what I'll talk about or think about. So people are always welcoming that information. Unless you're
Not
just,
all doctors.
unless you're just bugging them.
I mean.
But I don't get the impression you're the kind of guy that would
understand
just
the
bug.
need for all of the policies and things, because,
Yeah.
there has to be some way to control not only the patients, but the families and the doctors have lives, but, I can talk to you about somebody and to this point not give you any specifics of this individual.
Right, yeah.
And I can do the same thing. What I'm looking for, and forgive me, but I'm very frustrated. It's been 12 years, and I've had more of a struggle with the medical profession than I have with the individual. In getting information. What I'm trying to do is make some difference to the quality of life this individual has, and I don't, know if I'm sometimes the problem or the solution. There's nowhere to go to find out. And when I observe him, I don't know, I have a feeling that, and I'm almost sure that he is missing some of the medication on a regular basis.
Mm-hmm.
Partly because even though he now agrees to take it, without getting into his lifestyle, it's prone to be forgetting at times.
Mm-hmm.
And he doesn't really want to talk to me about the illness.
Right.
So, except that he has agreed that I can sort of look at his medication and,
Sure.
and we developed this idea with having a tray, and if it's swallowed,
Right.
then I can just look at it and I'll know if but sometimes he uses the jar or the bottle.
Right.
And, so it's.
For some people, it's hard for you and I to come up with solutions because that individual needs to be invested in the ideas that we talk about. So one of the ideas could be a long-acting injection. Now, you had a physical response when I said that.
Sorry.
Where you went, you kind of went, so I
Well,
thought, maybe you don't want to talk to him about that, or maybe that has already been discussed.
I haven't spoken to him about that, and as I said, we don't really discuss, he doesn't want to discuss anything with me because I'm the person that got him in hospital the first time, the second, the third,
Right.
the eighth.
Yeah.
And it's an ordeal, I'm sure people have gone through it. For him, just to go through the same process, even though he's on record to have schizophrenia, he goes through the same process to get put into the hospital, and he inevitably gets a different doctor every time, which makes me curious, but there's probably benefits for him in that. And and then he's released, and I guess one of my concerns is that, and I worked with the last doctor that he was under the care of, and she was great help, in getting something arranged for when he left the hospital, so it didn't all fall apart.
Right.
And the doctor at the time, who was his outpatient doctor, had decided that he needed this CRTC, I guess, where somebody administers the drug, because he can't be responsible. But he didn't want that and pleaded with both myself and that doctor for another opportunity, which, we said okay.
Yeah.
And then the system that was starting to be put together to help him at home, it's all falling apart now. And one big concern is that he's going to outlive me. He's a grown man, it's his life. And nobody's going to know where he's at.
Right.
He has missed appointments. He goes to a clinic. He doesn't have a pharmacist. He goes to a clinic and has blood work done, and he's given a month's supply of medication.
Where does the month supply come from? It's not a pharmacy?
I believe it comes from the hospital out to the clinic.
Yeah.
Positive.
Is it clozapine or?
Yes, it is.
Okay.
And they're aware that he, in the past, has missed some appointments.
Right.
Although he's pretty good at keeping them now, every month and going there. But it seems that, I guess I was hoping that when I got him in front of the right people, they would take the responsibility for his health and welfare. Meaning that they would know his condition and have something set up. And this is what I tried to do with this other doctor, get something in place so that if I was to pass away tomorrow, they would be able to monitor him on the outside.
So
But it's not really.
sometimes based on these kind of things, I try to come up with the most practical things because we're not going to change the gaps in the mental health system. So is there anything else that happens? Now, this Bloom program thing I've talked about is one thing, but another service that some pharmacies offer is daily delivery with observed medication taking.
Yes.
Would that be of any help?
I don't think it would be successful with this individual, but I mean, it would be up for, it would be his decision. Although he doesn't want anybody coming to his door. He just wants to be left alone, and I'm sure if he didn't have to take this medication, and again, I believe he's only taking it because
He doesn't want to
he doesn't have to go
go through the rigmarole. Yeah.
It's the lesser of two evils, you know what I mean?
Yeah.
Now, I could be wrong, but I don't think so.
Yeah.
And he's a wonderful person, and he's just unaware, he doesn't know that he's,
David, I think my husband and I are listening to this story, and our son was, it just sounds like such a familiar tale in so many ways. And I think, my gosh, the UK is smart. Like, it makes so much sense not to wait, not to treat the injectable form as, well, if we have to, we'll go to, if we have to. I mean, so many families struggle with a person who means well, who one way or another has come to accept that medication is a necessary evil.
Yeah.
I mean, I still think there are many days when my son feels that this is some sort of evil plot, this giving him this medication, and other days when he has better insight into it. But we struggled for 8-10 years with a boy who was repeatedly relapsing and back in hospital. And, we finally got around to being like, there is no other solution, because whether it's because he forgets or because he gets drunk and doesn't realize that 2 days have gone by without taking his medication, or because he's decided he's well enough not to worry about it anymore. For whatever reason, he was doing his best, but his best was actually causing eventual relapse. I don't understand why his very first psychiatrist didn't think, let's start here, because the chances are good that compliance is tough or impossible or something in between those two extremes. Like, is the UK getting better outcomes, fewer hospitalizations? Is there any
it's-
evidence around that?
I think there's so many differences across the health systems.
You can't
People
compare.
don't even try to
Yeah.
compare.
But families are struggling to figure out how they can get their loved one in a position where they're receiving a long-acting form so that nobody has to worry, is it a lack of compliance?
Yeah.
We
And
were fortunate though that he was in against his will, and that's when we all thought, start it now. Start it next episode in the hospital when he's in there against his will. And if he's in there for 2 or 3 months like our son has done, it has a chance to build up, and then he's on that even keel for a while. And maybe he'll agree that he's a benefactor of that.
you know, it's tough to leave it to the family to do battle for a way to get the injectables to our loved ones. And I, you know, much as I don't know that psychiatrists really understand this, if the psychiatrist had said to Tristan, this is the way, this is the best way, and you need to be doing this, us saying that is a very different, you know, independence battle. And it breaks my heart that you're in this situation with a person who deserves a better quality of life right now than he's got. And you're worried about what's going to happen once you're no longer around to be the watchful eye. So many of us are in that boat. And so, I don't know.
I agree with Lyndon. I think the psychiatrists really have to be a little more forceful, a little more. This is the way it's done. This is the way we're doing it.
Course of action.
You know, instead of letting them decide, you know, when they're really not. Yes, legally maybe they are capable of making their own decisions, but you know where this road is leading. So, you know, I just wish the psychiatrists were just more.
I mean, the cost for us is that our son's multiple relapses have resulted in part in cognitive impairment that I think would have been less severe had there been fewer relapses. But I didn't know what I didn't know about injectables when he was first ill.
Yeah.
And so there's this huge cost to my son, a cost to the family, a cost to society. And it seems to me like a pretty straightforward fix if we go with a more proactive approach to long-acting medications rather than
I think it's
sit back.
prescribing culture. So if you're in England, you present it as an early option, and you don't present it with any negativity.
Right.
Whereas whether you're here, it's not really offered by many early. So the early psychosis program, I think they're pretty good at offering.
This was offered to us for the whole period he was there, but he refused it.
Right.
So we had to wait till he was hospitalized against his will, and then we reinforced that notion with the good thoughts of the psychiatrist there.
But there could be quite a few solutions right in front of us. But when there isn't cooperation from the individual, there isn't a lot of options until the individual is so unwell they're hospitalized. And that is the way our system works.
You know, long-acting injectables are not right for everybody
No, I agree. I agree.
Like we've had 2 different times, my son has, and the side effects he found really difficult, and they weren't taken care of, or if they were taken care of, you know, you get other problems. So to him, it's the worst thing in the world to have an injection. It's, you know, it's terrible to him. So to take a pill, he's on clozapine, to take clozapine pills to him is so much better than taking an injectable.
It's possible
No,
that
there's
this
never
could be
been.
doing those injections. Since it's intravascular.
That's a really good question. So it's not done.
Take the stigma going to the doctor's office.
Yeah.
Put it in the community.
It's not done in Nova Scotia so far. So one of my students who graduated 3 years ago, she went out to Alberta and worked as a pharmacist out there. And she said, she emailed me a while later, said, guess what I do? And she was actually administering the long-acting injections. But, so we have the law, the pharmacy law, or the Pharmacy Act has been updated that says we can administer medicines. So what that means to every pharmacist means, oh, I can give flu shots when it's flu season. But the actual act now says we can administer medicines. So the regulations kind of follow along and the practice follows along after that. So it's possible. And we don't need new laws, new changes in laws to support that.
Dr. Gardner, you mentioned a few, earlier about the schizophrenia having sort of taking on a mind of its own.
The symptoms, yeah.
Right. So, in a person that, so in other words, it's like not being able to predict the illness? Is that
Right,
what
so,
you're-
so sometimes, I'll just give you an example of what I was trying to say there. Sometimes for some people, getting close to Christmas time, for whatever reason, causes deterioration.
Every fall.
Right. So it may be that the answer is just more medication. So one of the ways I describe what these medications do, that's not, something you see in the textbooks, but it's a way that I kind of see it is, it's resilience. If you're on the right dose, you're more resilient to dealing with what stresses you. So for some, I'll just give you an example. For a patient that I've had at the early psychosis clinic was, the person could not anticipate exams or even get to the exam period without suffering a relapse. But with the properly administered dose of risperidone, just regular old risperidone at a reasonable dose, the level of anxiety just didn't seem to bother him. And the preparation, therefore, was put into place, and the ability to do an exam and write an exam and build on that kind of success, because past the exam was there. So that kind of resilience, the ability to say, I can muster myself through this, was based on being on the medicine at the right dose, even at the most vulnerable time for that person. So that's kind of how I see it sometimes. It's just, is it the right medicine? Is it effective for you when you take it? And if the answer is yes, then maybe it will be effective for you if you can modulate the doses for when the illness is breaking through.
Well, this
We
may not be a
increase
perfect-
it a little bit.
Yeah,
Yeah,
increase
if
the
you're
dose.
getting,
Yeah.
if you're
And
getting,
that-
you're gonna be, or you are getting
Yeah.
stressed, increase it for a
Yes.
short period
Yeah.
of time.
So not a lot of patients will say to me, great idea.
If the
But it
person
actually
is-
is.
My daughter has done that, and we've known when that stress is,
Yeah.
and she doesn't have a problem taking another 50 milligrams, just to get her over that period
Yeah.
of time, and then
Yeah.
she goes back to her normal dosage.
If the patient's behavior is passive and they're non-violent, and this may not be a question for you, can that change over time, medication or not? In other words, could they become violent?
I think anything's possible, but I don't think that would be the expectation in any way. So if somebody's nature is not that way, that would predict
So
that would be their nature.
medication isn't really addressing, or if we have an effect either way on that.
No, not the medication. But when they're unwell, if they are non-violent, non-aggressive, which is the majority of people when they're unwell with psychosis, they're non-aggressive, non-violent. They're just unusual in a variety of different ways. They wouldn't expect to, at some point in their life, become aggressive because of the medications or because of the illness progressing. That wouldn't be the expectation.
Wouldn't it be a little bit towards what their delusions or hallucinations were leading them towards?
Yeah, but that would happen when they're younger too. So it wouldn't be like their delusions and hallucinations when they're older, after a couple of decades of the illness, would then change dramatically and become scary to them and have them lashing out because of that kind of thing. I'm not saying it doesn't happen. I said at the start it could happen, but it's not what's predicted to happen.
I'm going to have to end this here. David, do you realize
Is it midnight?
Well, no, we've all been sitting here, so I mean, it's been so interesting, but you know, it is 9:30. And Andrea probably is wondering, oh yeah, where did he go after right now? I let him out of the house. So, oh, thank you so much, David. I mean, it was wonderful.
You're welcome.
It was
Nice to
really-
see you.
it was wonderful. All right, we will have you back probably the year after next. Well, as a matter of fact, the 2016 National Conference that we're going to have this time next year will be the end of
Here in
October here in Halifax. And you're going to be a session on the Bloom program.
Okay.
Okay?
All right.
So that's it. All right, no, that's.
She did warn me a little bit before, so.
Okay, thank you very much.
Okay. Well, thanks again.
Okay. Wow, this
Thursday,
Oh.
no, not